Inshallah, we will continue the curriculum. As usual, the curriculum is 31 chapters from rhesus up to safeguarding and psychosocial emergencies in children. So the exam is 2 papers online. Each paper 2 hours and 1 hour break in between. You should follow the blueprint also. So rhesus, very, very important chapter. Allergy, cardiology, very, very important. To pass this exam, the most important rhesus, cardiology, trauma, and sedation. You have 4 important chapters: rhesus, cardiology, trauma, and sedation. ENT, elderly care frailty, endocrinology, environmental emergencies, gastroenterology, hematology, infectious disease, maxillofacial and dental, mental health, and today for musculoskeletal, non-traumatic. So you have trauma and non-trauma. So each topic we will discuss today, it's non-traumatic, no trauma in the scenario. Clinical presentation: acute back pain, limb pain and swelling, neck pain, joint swelling, acute hot swelling joint, and conditions related to this presentation, like Coda-Equina syndrome. So the most important for you to understand this acute back pain related to Coda-Equina syndrome or not, crystal-related arthropathies, septic arthritis. So regarding limb pain and swelling, is it crystal-related arthropathies? Is it septic arthritis? And so on. And limb pain and swelling may be bursitis, tendonitis, whatever in the upper and lower limb, maybe ruptured biceps, maybe Achilles tendonitis, plantar fasciitis, and so on. So you have to be familiar with this small differential diagnosis. Spinal pain and the radiculopathy. So neck pain, is it associated with spinal pain and radiculopathy? Risk of rheumatological disease modifying drugs. Spinal infection. So spinal here related to acute back pain and neck pain. So maybe the patient has acute back pain because of infection and maybe neck pain because of infection. Torticollis in pediatric, limbing child pediatric, osteochondritis pediatric. So first of all, acute back pain. So nice guidelines say low back pain, pain in lumbosacral area of the back between the bottom of the ribs and the top of the legs. So we are talking about low back pain. Maybe non-specific low back pain, when the pain cannot be attributed to a specific cause, may be related to trauma, musculo-ligamentous strain, period of little pain or disability are interrupted by acute episodes of severe pain. So this non-specific low back pain. Sciatica, we have sciatica and Coda-Equina syndrome. Of course, Coda-Equina syndrome, you have specific symptoms we will discuss now. Otherwise, it's sciatica. So sciatica, sometimes unilateral, sometimes bilateral. Don't think if the patient has bilateral symptoms, it's Coda-Equina. Maybe it's sciatica, bilateral sciatica, okay? Symptoms of pain, tingling, numbness arise from impingement of lumbosacral nerve roots as they emerge from the spinal canal and are felt in the distribution of the nerve root, dermatome. So the patient has impingement of the nerve roots, not the spinal cord. Coda-Equina syndrome, it's a compression of the spinal cord itself. The difference between sciatica and the Coda-Equina syndrome, sciatica, it's impingement of nerve roots coming from spinal cord. But Coda-Equina, it's compression of the spinal cord itself. So this patient, he will get pain, tingling, numbness, and it will be felt in the distribution of this nerve root. It's called dermatome. There may be accompanying motor weakness in corresponding myotomal distribution. So lumbosacral nerve roots, guys, you expect which nerve roots? Anyone has idea?
L4, L5, S1, S2.
S1, S2.
So you can think about lumbosacral. We are talking about lower. So whatever lumbar 4 or lumbar 5, S1, and so on. Symptoms of sciatica typically extend to below the knee. So if you find in the scenario, the symptoms below the knee, from the buttocks, across the back of the thigh, to the outer calf, and often to the foot and the toes. Here, of course, acute back pain may be traumatic. It will be mentioned in the scenario traumatic. The patient has RTA or he has fell down or something like that. But today we are talking about non-traumatic pain. So non-traumatic here, it means maybe the patient has infection, inflammation, malignancy, okay, and so on. So how to deal with acute back pain? The red flags, if mentioned in the scenario trauma, so it's a red flag, it needs X-ray or any imaging, whatever X-ray or MRI or CT. So if you have suspicion of bone problem, X-ray or MRI or CT. If you have suspicion of malignancy, MRI. If you have suspicion of any spinal cord problem, MRI. So red flag trauma, unexplained weight loss, so maybe infection or malignancy, neurologic symptoms, so maybe Coda-Equina syndrome, age more than 50, fever means infection, intravenous drug use, so high risk for infection, steroid use, high risk for infection, means the patient immunocompromised, history of cancer, it's a high risk for metastasis. Okay, so you can check this algorithm if low risk, intermediate risk, and high risk. Okay. So regarding sciatica, the compression can be caused by maybe herniated intervertebral disc, whatever lumbar 4, lumbar 5, or lumbar 5 S1. So you have two levels. You have two levels. We are talking about low back pain. So lumbar 4, lumbar 5 means the disc between them. The herniated intervertebral disc, guys, will do compression on the spinal cord or impingement of the nerve roots.
Mainly nerve root.
Yes, nerve roots. So the disc between lumbar 4, lumbar 5, or the disc between lumbar 5, this one. It will cause here compression on L4 nerve roots or L5 nerve roots.
L5.
Excellent,
L5.
L5. And regarding the level of L5, S1, it will cause compression on which nerve roots, L5 or S1?
S1.
S1. So it can make compression on the nerve roots below, okay? Below. Spondylolisthesis. So vertebra moves forward relatively to distal vertebra. So here the disc herniation, and here you have two vertebra, whatever lumbar 4 and the lumbar 5. What happened here? The vertebra lumbar 4 go forward in relation to lumbar 5, but no disc herniation. So it's called spondylolisthesis. Spinal stenosis, it means narrowing of the spinal canal. And this one relieved by forward flexion and worsened with extension. So if the patient has any symptoms and you ask him or mention in the scenario relieved by forward flexion, worsened with extension, so it's a spinal stenosis. Infection. So if you have in the scenario, this is how you study, guys. It's not about reading or not about memorizing. Ask yourself how the scenario will come to you. Okay. So regarding infection, how to understand the diagnosis. The patient has back pain in the scenario. How to understand its infection. So you will find the high risk for infection. For example, the patient IV drug user, the patient has diabetes mellitus, the patient, I'm talking about any infection in any scenario. So you will find risk factors in the scenario. Patient has fever, diabetes, immunocompromised, maybe using steroid, maybe he has a history of HIV, maybe he has comorbidities, okay? So discitis, think about discitis, means infection of the disc between vertebrae, and maybe vertebral osteomyelitis in the vertebral body itself, or spinal epidural abscess, so infection around the spinal cord. What about malignancy? So if they mention the patient has constitutional symptoms and back pain, for example, the patient, he has 60 years and he has back pain, low back pain, and he has weight loss, loss of appetite, night sweats, mild grade fever. So fever here may be infection or malignancy. Fever with constitutional symptoms, malignancy, fever without, so it's infection. So if you find symptoms of malignancy, but the patient doesn't have history of cancer, so this one primary or secondary malignancy?
Secondary.
Primary. If he doesn't have history of cancer, so it's a primary, okay? So maybe he has tumor in the spinal cord, compressing the spinal cord, and this one primary. He doesn't have any other malignancy in other part of the body. But for example, the patient has history of cancer lung 20 years ago or 10 years ago, and now he has symptoms of numbness, tingling in the legs, and he has back pain. So this one primary or metastasis?
Mets.
metastasis.
Metastasis.
Okay, so this is how to select the scenario. Okay, suspect sciatica. So again, here we have two levels, lumbar 4, lumbar 5, and lumbar 5 S1. Why? We have two nerve roots. So this nerve roots between lumbar 4, lumbar 5, as you see, and the other one between lumbar 5, S1. So it will cause compression on the nerve root, but the spinal cord may be normal. Okay, the nerve roots on, and it will cause compression on the nerve roots below. So we have lumbar 4, lumbar 5, it will affect lumbar 5. We have lumbar 5, S1, it will affect S1, and so on. So how to suspect sciatica in the scenario? If you find in the scenario the patient has unilateral leg pain radiating below the knee to the foot or toes. But again, don't rule out if bilateral. Okay. Low back pain, if present, it is less severe than the leg pain. Again, low back pain, less severe than the leg pain. So the patient has back pain and the leg pain. If you will ask him which is more, back pain or leg pain, he will say leg pain. I have severe leg pain. He's complaining leg pain, not back pain. If you ask him, do you have back pain? He will say, yes, I have back pain. But his concern, leg pain, because it's more severe. So it's a sciatica. In coda equina, the opposite. He will say, I have back pain. If you ask him, do you have leg pain? He will say yes, but his concern is back pain. Numbness, paresthesia, muscle weakness, or loss of tendon reflexes. So if you find in the scenario numbness, paresthesia, muscle weakness, loss of tendon reflexes. Okay, lumbar 4, lumbar 5 disc prolapse, it will cause compression or pressure on lumbar 4 nerve roots. L5 S1 disc prolapse, pressure on S1 nerve root. You have 3 tests in sciatica. It can be questioned in the exam. So the first one, this one, positive straight leg raising test. Raising the leg straight causes greater pain radiation below the knee and or more nerve compression symptom. So if the patient is complaining of numbness, paresthesia, muscle weakness, and you raise the leg, it will cause exacerbation of these symptoms. You will feel more numbness, more paresthesia, and weakness, and you will feel pain also. It will increase the pain. So it's a positive. This one, he has sciatica. Okay. In coda equina, no. If you raise the leg, it will not affect. Sciatic stretch test. So you will do dorsiflexion like that. You will move the foot forward while the leg is raised. It will exacerbate pain. So it's a positive. It means sciatica. The last one, extensor plantar response, like that. So you will do a stimulation of the lateral part of the sole. What happened? Toes extend and fan forward, like that. So the normal patient, if you will do like that, the toes down, it will cause flexion. But if go up and fanning like that, so this one abnormal. It's called Babinski sign. So if you find Babinski sign positive, it means sciatica. We said we have 2 levels, lumbar 4, lumbar 5, and second level, lumbar 5, S1. So here, involvement of lumbar 5, the one below, and here, involvement of S1, so the one below. So what are the symptoms here? What are the symptoms here? So they can ask you in different way. They can tell you the patient has involvement of lumbar 5. What are the features to support your diagnosis? or they can ask you the opposite way. They can give you this features and they can ask you which nerve root involved. Okay, so regarding lumbar 5, how to differentiate between lumbar 5 and S1? Lumbar 5, weakness of excitation of the great toe. Okay, decrease the sensation in the first web space. So which one is first, guys? Lumbar 5 or S1?
L5.
Which one is first, great toe or small toe?
Great toe.
So remember like that. So lumbar 5 before S1, great toe more before small toe. Okay. So weakness of excitation of great toe, decrease the sensation in the first web space. It means motor and the sensory. Motor and the sensory. Okay. Web space means between the first and the second toe. What about reflexes? Normal. So if you find the reflexes normal in the scenario, it means lumbar 5. Okay. If you find decreased or absent ankle jerk, it means
S1.
okay. So again, big toe means
L5.
L4. L4, L5. So it means nerve root L5. And here L5 S1, it means S1.
S1.
Okay, you have to level L4 L5 and L5 S1. This one it will affect L5, this one will affect S1, this one big toe, motor,
Big toe.
and web space sensory. And what about reflexes here?
Normal reflexes.
Normal. And here decrease or absent ankle jerk.
Absent ankle.
Okay, and the small toe. Okay, remember. Okay, so again, we have differential diagnosis of low back pain. Okay, so you have two types inside the spine or outside the spine. The patient has back pain. This related to the spine or not related to the spine. So related to the spine, it means the problem in the spine or vertebra. Not related to the spine, it means something not related to the spine like vascular, GIT, genitourinary, or others. Okay, so if the patient has back pain, don't think the problem in the back. Okay, so maybe non-specific low back pain, as we mentioned in the start, maybe structural degenerative disease in the vertebra, maybe inflammatory, maybe infection, maybe malignancy. Structural, like the patient has vertebral fracture due to trauma or osteoporotic collapse. So if the patient has fracture with trauma, so it's a vertebral fracture, normal. If the patient has fracture and no trauma, so what does it mean, guys? Osteoporosis. Okay. Intervertebral disc prolapse, so it's a structural also. Spinal stenosis, structural. Koda-Equina syndrome, back disease, or other metabolic disease, spondylosis, spondylolisthesis. Inflammatory conditions may be ankylosing spondylitis. So what does it mean, ankylosing spondylitis, guys?
Fusion of spine.
Yes, excellent. Fusion of spine. We will discuss now. Other like Reiter syndrome, psoriatic arthritis, enteropathic arthritis. Also inflammatory, polymyalgia rheumatica, sacroiliitis, sacroiliac dysfunction. Infection, as we mentioned, discitis, vertebral osteomyelitis, bacterial or tuberculosis, maybe abscess. Malignancy may be primary or maybe secondary. If primary, the patient doesn't have any history of cancer, so he has only constitutional symptoms and no history of cancer. So think about myeloma, think about osteosarcoma. If they ask you what is the most likely diagnosis, check in the scenario. Any past history? No. So what is the most likely diagnosis? If you find the myeloma, choose. If you find osteosarcoma, choose. Secondary malignancy, you will find in the scenario, the patient has back pain, he has fever, and he has constitutional symptoms, and he has history of breast, if female, lung, male or female, prostate, male, renal, and thyroid, maybe in the scenario. So any of them, so what is the most likely diagnosis? Metastasis. So spinal cord metastasis. What about non-spine causes of acute back pain? So if you find in the scenario the patient more than 50 or 55 and he has back pain plus or minus flank pain or abdomen pain, so think about AAA, also maybe aortic dissection. So if he has acute back pain thoracic, think about aortic dissection. And also sometimes it's referred to back, as you remember in cardiology. Ruptured leaking aortic aneurysm, so maybe the patient has low back pain. GIT, maybe peptic ulcer disease, maybe pancreatitis, okay. Maybe retroperitoneal perforation of colon. Genitourinary, maybe the patient has pyelonephritis, renal calculi, prostatitis, pelvic infections. Also shingles. If the patient has any pain in any part of the body, expose the area. If the patient has chest pain, maybe shingles. Back pain, maybe shingles. Okay. So at any pain, expose the area. Maybe it's rashes. Okay. So red flag symptoms and sign. Think about red flags for coda equina, red flags in the scenario to diagnose a spinal fracture, and also for malignancy, for metastatic, and infection, inflammatory disease. We will discuss each one. So coda equina syndrome in the scenario, you will find severe or progressive bilateral neurological deficit of the legs, such as major motor weakness with knee extension, ankle eversion, foot dorsiflexion. Okay. Perineal sensory loss. So it's called sudden anesthesia or paresthesia. It can be by different ways. So they can tell you the patient has diagnosed with coda equina syndrome. Which of the following support your diagnosis? Which of the following you will expect on examination? So you will choose any one of them. Or the other way, they can give you these features or one of them, and they will ask you what is the most likely complication, what is the most likely diagnosis. So recent onset bladder dysfunction, whatever retention or incontinence. Recent onset fecal incontinence, whatever also constipation or incontinence. Laxity of anal sphincter on examination. So you will do PR, digital examination. A spinal fracture, you will find in the scenario, of course, a trauma, or maybe non-traumatic. If non-traumatic, it will be osteoporosis, as I mentioned. So you will find sudden onset, severe central spinal pain, which is relieved by lying down. Major trauma, such as RTA or fall from height, maybe minor trauma, or even just strenuous lifting in people with osteoporosis. So maybe traumatic, or maybe non-traumatic osteoporosis, or those on corticosteroid. So if they mention in the scenario, the patient has, for example, using steroid, and he has fracture, sudden onset central pain. So think about osteoporosis, think about also non-traumatic fracture. Structural deformity of the spine, bone tenderness over vertebral bone. So if you find these features, it means spinal fracture. Malignancy, you will find the patient more than 50 in the scenario, gradual onset of symptoms, severe unremitting or progressive lumbar pain that remains when the person is supine. So supine here will be specific in the scenario. Aching night pain, so it's specific for malignancy. Prevents or disrupts sleep, specific. Pain aggravated by straining, so malignancy. Pain in the thoracic or cervical spine, localized spinal tenderness, no symptomatic improvement after 4 to 6 weeks of conservative low back pain. So any patient with non-specific back pain, you will give just simple analgesia and discharge the patient. If the patient did not improve after 4 to 6 weeks, think about what, guys?
Malignancy.
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 Okay, so any patient has non-specific low back pain. What does it mean, guys, non-specific low back pain?
No, and I identified cause.
Okay, what else? No red flags. No red flags. It means the patient doesn't have Kodak-Wine syndrome. The patient doesn't have malignancy. The patient doesn't have infection. The patient doesn't have fracture. It means it's a non-specific low back pain. You can discharge the patient. Okay. No red flags, symptom or signs. It means non-specific back pain. So this patient, you will discharge with simple analgesia, and if not improved after 4 to 6 weeks, you will think about malignancy. Unexplained weight loss, past history of cancer. So maybe primary or secondary. Metastatic spinal cord compression in patient with cancer, so secondary. Means spinal metastasis. If they ask you, what is the most likely diagnosis? Spinal metastasis. You will find the radicular pain, limb weakness, difficulty in walking, sensory loss or bladder bowel dysfunction, neurological signs of spinal cord or Kodak-Wine compression. Infection, you will find in the scenario fever. Maybe he has history of TB. So it's intrapulmonary or extrapulmonary.
Extrapulmonary.
Okay. Or recent UTI. So if the patient has whatever pyelonephritis or UTI in any other site, so maybe referred to the back, spread of infection, diabetes, risk factor, history of intravenous drug use in the scenario. So think about infection, HIV infection, use of immunosuppressants, or the person is otherwise immunocompromised. So these risk factors for infection. Inflammatory disease, the patient is less than 40. What about malignancy? More than 50. So if less than 40, think about inflammatory until proven otherwise. Pain at night, also malignancy. Aching night pain is not relieved when the person is supine, but in malignancy remains when the person is supine. Okay. Stiffness in the morning. So this one's specific for inflammatory. If you find that in the scenario, so it's inflammatory. Relieved with movement, exercise, specific. Gradual onset of symptoms, symptoms that have lasted for more than 3 months. So if the patient has symptoms more than 3 months, think about infection. So if you find symptoms of infection, again, guys, it's very important. Can be common question. Discitis means infection or in the disc between vertebrae, or maybe vertebral osteomyelitis or spinal epidural abscess. It can be common question. So if you find the discitis, choose. If you find vertebral osteomyelitis, choose. If you find the spinal epidural abscess, choose. And of course, as the management will be painkiller, analgesia, and will be also antibiotic. Spondylolisthesis, so defect or stress fracture in the pars interarticularis of vertebral arch, lower lumbar vertebra, number 5, but also can occur in the cervical vertebra, children and adolescents. So if you find the age of children or adolescents, think about this diagnosis. So maybe they are doing gymnastics or football or weightlifting. So think about that diagnosis. So what about investigation in general? Whatever the cause, whatever the red flag, what you will do? You have a spinal X-ray, MRI, FAST, and the bloods. Okay. So here regarding investigations, I went to do X-ray, I went to do MRI, and I went to do FAST, I went to do bloods. Okay. So the spinal cord spinal X-ray, if the patient has history of trauma in the scenario, and they ask you what is the investigation, of course, X-ray. First of all, X-ray. Suspicion of malignancy. If you feel the diagnosis as malignancy, so first of all, X-ray. Fracture or metabolic bone disease. So whatever traumatic or non-traumatic, and you feel features of fracture, so X-ray. What about MRI? When to do? Suspect Coda-Equina syndrome, suspect spinal cord compression, infection, inflammatory disease, malignancy. So you can choose MRI. If you suspect AAA or aortic dissection, so the scan here fast. If the patient is unstable, of course. If the patient is stable, what is the investigation of a choice here?
Ultrasound.
Honest-
CT angiography.
CT angiography. Excellent. So if the patient is stable, CT. If the patient unstable, fast. Okay. What about bloods? Inflammatory markers, of course, infection. Nice guidelines. If there are red flag symptoms or signs, admit or refer urgently for specialist assessment or imaging using clinical judgment. Treat the underlying cause. So red flag for infection, treat the infection. Red flag for malignancy. So manage as you can and refer to a specialist. You find Coda-Equina syndrome, so this patient needs urgent cord compression. No red flag symptoms, what you will do? So it will be non-specific back pain. Just to offer self-management advice, inform the patient what to do, offer analgesia for pain. So already you will give the patient analgesia. Which analgesia? Oral, non-steroidal anti-inflammatory drugs like ibuprofen for managing low back pain, taking into account potential differences in GIT, liver, cardio-renal toxicity, and the person risk factors, including age. So you will choose non-steroidal anti-inflammatory drugs according to these factors. Prescribe oral non-steroidal anti-inflammatory drugs for low back pain at the lowest effective dose for the shortest possible period of time. So you will choose the lowest effective dose and shortest possible period of time. What about weak opioid? You will choose in the scenario or not. So with or without paracetamol for managing acute low back pain, only if non-steroidal is contraindicated, not tolerated, or has been ineffective. So if they mention clearly in the scenario, the patient contraindicated for non-steroidal anti-inflammatory drugs, so choose opioid, with or without paracetamol. If they said not tolerated, so choose opioid, with or without paracetamol. If they said the patient on non-steroidal anti-inflammatory drug, but not responding to pain, so with opioid, with or without paracetamol. So again, when you are studying any guidelines, so each point can be a scenario. Neuropathic pain guideline for the management of sciatica. If they mention the patient has neuropathic pain, what is the treatment? So amitriptyline, duloxetine, gabapentin, pregabalin. So any of them, if you find it, choose. What about tramadol? Should only be considered if acute risk therapy is needed. The patient is not responding. Benzodiazepine can be considered for muscle spasm. So if they say the patient has back pain and he has a spasm, so diazepam 2 mg TDS for up to 5 days. Remember that, please. Diazepam 2 mg TDS for up to 5 days. The following are pharmacological therapies not recommended by NICE, not recommended. So if you find in the scenario paracetamol, don't choose. If you find in the scenario the patient has chronic low back pain, don't choose opioid. If you find in the scenario serotonin reuptake inhibitor, don't choose. If you find serotonin noradrenaline reuptake inhibitor, don't choose. Tricyclic antidepressant for non-neuropathic pain, don't choose. Non-neuropathic pain, don't choose. So he went to choose in neuropathic pain, okay? But non-neuropathic pain, don't choose these drugs. Anticonvulsants, don't choose. So patient has a spasm, don't choose anticonvulsant. You can use also benzodiazepine only, diazepam only. So what is the scoring system here for back pain? So start back tool scoring system. It's unlikely to ask you about these questions, but at least you'll be familiar with the name of the score. Musculoskeletal presentation number 2, limb pain and swelling. If they mention in the scenario, the patient has limb pain and swelling, so think about maybe the problem from out to inside, from outside to inside. So the skin, after that, below the skin, subcutaneous tissue, and below that, inside artery, maybe vein, maybe lymphatic, maybe bone inside. So if the patient has problem in the skin, maybe insect bite. The patient has limb swelling, maybe insect bite. Whatever insect bite here, it can cause allergy, swelling, or it can cause cellulitis. Okay, subcutaneous tissue. So infection of the subcutaneous tissue, as we discussed in previous chapters, cellulitis. Artery, maybe the patient has trauma. After that, he has compartment syndrome. If you mention compartment syndrome, mention acute limb ischemia because both related to the artery. So here, bleeding inside, and it can cause compression of the artery. It can cause compartment syndrome and limb ischemia. What about vein? So thrombosis, maybe superficial thrombosis, maybe deep thrombosis. Lymphatic system, so it's lymphedema. Bone might be sarcoma, so like Ewing sarcoma. So what about the management? Analgesia, we are talking about pain. X-ray to exclude any fracture or osteomyelitis or sarcoma. X-ray. Doppler ultrasound for artery and the vein. And of course, any swelling as a routine management. Rest ice elevation. Treat the underlying cause, whatever. If you find it's insect bite, treat. Cellulitis, treat. Compartment syndrome, treat. Venous thrombosis, whatever superficial or deep, treat. Sarcoma, treat. And refer to specialist according to the underlying cause. I think it's clear now. One of the common scenarios, what is the diagnosis, guys?
Bringing of scapula.
Bringing of scapula.
Yes.
Long
So-
thoracic nerve.
Thoracic nerve.
So it's a
Serratus
medial
anterior.
winging, medial winging of scapula. What does it mean, medial? So the normal here, can you see this is normal? So if you draw vertical lines like this vertical line, okay, this is normal. It means the border of the scapula in the same vertical line. If you find the border of the scapula, this one medial or lateral?
Medial.
Medial. So if you, this is a normal one, like this one, vertical. If you find the angle of scapula in the medial side between the midline and this line, so it's a medial wing. If you find the angle here, so it's
Lateral.
lateral winging. Okay, so it's a not important in the exam. Just if you find this, it's a winging of a scapula. And here they can give you a scenario, whatever the patient has trauma, or the patient has what else, guys? Non-traumatic cause.
Operation.
اللي هي أيوة surgical.
Chest drain and sepsis.
Breast surgery before in the scenario. Okay. So anyway, they can ask you 3 questions. The first question, what is the finding in the image? So right side, medial winging of scapula. What is the muscle affected? So right serratus anterior muscle, choose. What is the nerve? Right long thoracic nerve. And also it can happen if the patient is doing a procedure. Which procedure, guys?
Chest drain.
Chest drain, excellent. Chest drain. So if the patient is doing chest tube, whatever chest tube open technique or Seldinger technique, open technique in traumatic, intention pneumothorax or massive pneumothorax, or the patient is using Seldinger chest tube in a spontaneous pneumothorax. Okay, so it can injure the which nerve? Long thoracic nerve. That's why the new guidelines just anterior to mid-axillary line. Before it's anterior, it can cause long thoracic nerve injury. That's why now just anterior to the long thoracic nerve. What is the diagnosis?
Left frank injury.
fracture.
Yes, you have different names. If you find this image or this X-ray fracture or dislocation, they can ask you what is the most likely diagnosis. If you find less frank fracture, choose. If you find less frank dislocation, choose. If you find less frank fracture dislocation, choose. If you find tarsometatarsal injury, choose. If you find the midfoot injury, choose. So always be familiar with different names. Maybe you understand it's less frank fracture. If you find the midfoot, you will not choose. No. Okay. If they mention in the scenario and they did not give you X-ray or image, and they mention in the scenario the patient has ecchymosis midfoot, what is the diagnosis?
Less frank.
Less frank.
Okay. So expect that. So it can give you whatever X-ray, whatever image, or nothing of them, but they will mention the patient has ecchymosis in the foot. So they can give you scenario and the most likely diagnosis. So, for example, Lisfranc frank injury. Our chapter today, non-traumatic. So you have two mechanisms of injury. Maybe trauma, so something heavy fell on the foot. Of course, it will cause trauma. But today our chapter is non-traumatic, musculoskeletal non-traumatic. So the mechanism here, the patient, for example, riding a horse and fell from horse, it's not traumatic, fell from horse, no trauma. But what happened in the foot? Rotational force on plantar flex forefoot. So they can ask you what is the mechanism of injury. So you can choose rotational force on plantar flex forefoot or midfoot. Investigation, as you see here, X-ray. If they give you X-ray and ask you for investigation, so will be
CT.
CT. So if they ask you without X-ray, what is the initial investigation? X-ray. If they give you X-ray, what is the next investigation? CT. Management. You can fix this management for any orthopedic case. Remember that, please. Analgesia, neurovascular assessment, back slap, elevation, orthopedic repair. So any fracture, any dislocation. So you will say analgesia, neurovascular assessment, back slap, elevation, orthopedic repair. If the patient needs reduction, you will add reduction. So here analgesia, neurovascular assessment, I will add here reduction, whatever fracture or dislocation, okay, and you can continue. So fix this management, please, in any upper, lower body fracture or dislocation. Neck pain, presentation number 3, neck pain. So the patient may be non-specific neck pain, acute disc prolapse, acute torticollis, maybe trauma, whiplash type injury, adverse dystonic drug reaction, maybe you give the patient antipsychotic drugs or metoclopramide, arthritis of cervical spine, cervical strain or fracture, dislocation, myelopathy, cervical radiculopathy. What is the difference between myelopathy or radiculopathy, guys? So muscle.
Myelopathy, muscle involvement.
Yeah, so here motor sensory. Fibromyalgia, psychogenic condition, infections like meningitis, osteomyelitis. We said here neck, so maybe meningitis. Malignancy, neurological disorder leading to dystonia. So maybe the patient has a stroke or encephalitis, that's why he has symptoms neurology. Whiplash injury, what does it mean? They will mention in the scenario, the patient has acute whiplash injury, or maybe they will not mention that. So they will say the patient has sudden hyperextension or excessive hyperextension or hyperflexion or rotation of the neck, can cause neck pain and other symptoms. May result from rear end or side impact motor vehicle collision, but it can also occur during diving. Neck pain, which may be referred to the shoulder or arm, headache, reduce the range of neck movements, muscular spasm, stiffness, deafness, dysphagia or nausea, fatigue, dizziness or paresthesia. This one is common. Memory loss, temporomandibular joint pain, tinnitus. So any of them you can think about whiplash injury. Assessment. So history taking. Don't examine neck movements until clinical features may indicate serious injury have been excluded. So you will check cervical clearance. We will discuss later Canadian spine rule and Nexus rule to exclude first any injury. After that, you can examine the patient. So any patient with neck pain, trauma, or non-traumatic, so exclude first fracture. If trauma, so you will put cervical collar and finish primary survey, and in the secondary survey, remove cervical collar. Before you remove cervical collar, you have to exclude injury. It means cervical clearance. Two rules, Canadian and Nexus. Palpate the neck. So after you clear cervical, so palpate the neck for tenderness and assess neck movements if when appropriate. Apply Canadian spine rule in people aged 65 years or under to determine whether X-ray of cervical spine is required for diagnosis, fracture, or dislocation. Evaluate for evidence of neurological involvement. How to understand this patient needs imaging or not, guys? Patient has neck pain, whatever.
Dangerous mechanism of injury. First, we have to rule out that.
So check neurological involvement. If the patient has decreased in sensation, strength, abnormal reflexes, so this patient needs imaging. So if the patient have myelopathy or radiculopathy, if you mention in the scenario clearly any features of myelopathy or radiculopathy, so this patient needs imaging, whatever X-ray or MRI. Management, reassurance that recovery from whiplash-associated disorder usually occur within the first 2 to 3 months. Encourage early return to usual non-provocative pre-accident activities and early mobilization. Discourage rest, immobilization, and use of soft collars. Okay, joint swelling. Number 4, hand signs of rheumatoid arthritis. So as you see, they can give you this X-ray or the same, this image. So positive metacarpophalangeal squeeze test means if you will do compression by 2 fingers, your thumb and the index, you will do compression here. It will be positive. The patient has tenderness. So it's rheumatoid arthritis. Joint swelling, as you see, redness, heat, particularly the carpophalangeal joints, proximal interphalangeal joints, subluxation and ulnar deviation. So if they ask you by different ways, the patient has rheumatoid arthritis, which of the following support their diagnosis, or the opposite, they can give you the feature and ask you what's the diagnosis. Botonier deformity, as you see, and the swan neck deformity, as you see in the image. The deformity of some, this one. Posturing sign, inability to make a fist. If you ask the patient to make a fist, he cannot do. Or flex a finger, he cannot do. So investigation, of course, X-ray, and regarding the inflammatory markers, so full blood count, CRP, SR, 20s, liver function test. X-ray, you will find erosions. You can ask you what are the findings in the X-ray. Erosion, soft tissue swelling, joint space narrowing, periarticular osteoporosis, joint deformity. Anyway, it's not emergency for us. It's not our duty, but you have to be familiar with that.
Dr. Hani,
Yes.
please, can we take 10 minutes to pray Maghrib, please? Or 5 minutes?
Okay. Yeah. Sure. Me also. Yeah. Thank you.
Okay. Thank you.
Thank you. 10 minutes, guys, break. Okay, guys, we continue presentation number 5. Acute hot swelling joint. So one of the scenarios, gout. So how to diagnose that? They will mention acute pain in a joint, become swollen, tender, erythematous, reach its crescendo over 6 to 12-hour period, highly suggestive of crystal arthropathy. Also, you have another differential diagnosis, pseudo-gout, but this one much less likely. So if you find they mentioned in the scenario, the patient has first metatarsal phalangeal joint is the most commonly affected joint in acute gout. So if they ask you, is this gout or pseudo-gout? So gout. Underlying cause of gout, hyperuricemia, can be another question. The clinical diagnosis can be confirmed by presence of negatively, remember that, negatively finger perforingent crystals and synovial fluid aspirate. So think about gout, think about pseudo-gout, and think about negative, okay? Treatment of acute attack, generally with either non-steroidal or colchicine. Also, they can give you this image. So the diagnosis here, gout also. So this one, Tofi. Deposition, monosodium urate crystals. It will be in fingers, toes, helix of ears, elbows, prepatellar bursa, eyes. It can be any of them, any image of them, and they can ask you for the diagnosis. Condition, musculoskeletal, condition number 1, Coda-Equina syndrome, according to the Royal College. So clinical features, as we said, red flags, check red flags. And they can ask you about the causes. There is difference between what is the most likely cause and what is the most likely diagnosis. So Coda-Equina syndrome, it's not cause, it's a diagnosis or complication. It's not cause, okay? If they ask you about the cause, think about herniation of lumbar disc. This is the most common cause. If they give you a scenario with these features and they ask you about what is the most likely cause, don't say Coda-Equina syndrome. It's not cause. It's a diagnosis or complication happened. So choose, if you find herniation of lumbar disc, choose tumor, whatever, metastasis, lymphoma, spinal tumor, choose trauma, infection. As we mentioned, all differential diagnosis. MRI scan, of course, because it's a neurological problem. So the gold standard investigation of choice to confirm the diagnosis and determine the level of compression and any underlying cause. So it can show you if malignancy, tumor, also if infection, CT myelogram or standard CT scan, if MRI is contraindicated or not available. So if they mention clearly in the scenario, MRI contraindicated or not available, so CT myelogram or standard CT scan. Plain radiographs, limited value. If there is gross degenerative or traumatic bone disease. So if you think or suspect of traumatic disease, traumatic fracture. Condition number 2, crystal-related arthropathies. So gout here, diagnosis is usually a clinical one. You will find in the scenario or in the image, red, hot in the scenario, tender in the scenario, a swollen joint in the scenario or the image. Arthritis, so you will find in the scenario the patient has a swelling, redness, warmth, pain on passive movement especially first metatarsopharyngeal joint. So what is the diagnosis? Arthritis. If they give you these features in the scenario, it means it's arthritis. If you find firm white nodules, whatever in the scenario or in the image, over extensor joint aspect, so it's a TOFO. So both of them, it's gout. Both of them, gout. Affects metatarsal phalangeal joints of great toe, fingers, wrist, knee, ankles. Again, caused by hyperuricemia. Metabolite of purine, and the majority of uric acid usually excreted renally. The presence of monosodium urate crystals in synovial fluid or TOFO is diagnostic of gout. So this one, diagnostic, monosodium urate crystals. When these crystals are examined under polarized light, negatively perfringent. So gout and septic arthritis, what is the difference between them? So to diagnose, the joint has been aspirated for Gram stain to differentiate between gout and septic arthritis. Risk factors for gout, maybe the patient in the scenario is using diuretics, so we will understand it's gout. Renal disease in the scenario, family history of gout. The patient is using alcohol in the scenario, physical trauma or recent surgery, metabolic syndrome, he has hyperglycemia, hyperlipidemia, hypertension, obesity. So any of them, it means gout. What about the treatment? So it depends on the attack, acute attack or not. So in acute attack, non-steroidal anti-inflammatory drugs is the first line. So if you find non-steroidal in the scenario, choose. If you find naproxen 750 milligram, choose. So it will be stat dose followed by 250 milligram TDS. Colchicine, it can be used as alternative for risk factors for GI bleed or heart failure or allergy. So if they mention clearly the patient is allergic to non-steroidal, colchicine. They mention the patient has heart failure, colchicine. Patient has GI bleed, whatever present or past, so colchicine. Colchicine effects on the bone marrow. This is the adverse effects. It can affect the bone marrow. It can cause neutropenia, thrombocytopenia. That's why if the patient has gout and acute gout, and you will prescribe colchicine. So what is the treatment, guys, here? He has blood disorder, and you know colchicine, it will affect the bone marrow. It will cause neutropenia, thrombocytopenia. So what is the appropriate treatment? What do you think?
Steroid.
Yes. You will go back to non-steroidal or you will go for corticosteroid?
Corticosteroid.
Corticosteroid. So don't go back. So here, if you will give colchicine, it means the patient maybe has allergy, maybe he has heart failure, maybe GI bleed. So don't go back to non-steroidal. You have to go for corticosteroid. Effective alternative in the management of acute gout in patients with contraindication to non-steroidal anti-inflammatory. Appropriate treatment. What do you think?
Steroid.
Yes. You will go back to non-steroidal or you will go for corticosteroid?
Corticosteroid.
Corticosteroid. So don't go back. So here, if you will give colchicine, it means the patient maybe has allergy, maybe he has heart failure, maybe GI bleed. So don't go back to non-steroidal. You have to go for corticosteroid. Effective alternative in the management of acute gout in patients with contraindication to non-steroidal anti-inflammatory and also contraindication to colchicine. Okay, you can give oral, IM, IV, intra-articular. You can inject in the joint. What about prophylaxis? We finished already acute attack. What about prophylaxis? So you can use allopurinol once acute attack resolved. So don't give until you manage the acute attack. It should not be started in the acute phase. Why? Increase the severity and the duration of symptoms. If you will give the patient allopurinol first line, the patient will worsen and increase in duration. Aiming for plasma urate level less than 6 milligram. Okay, so what about the target of prophylaxis? You will give the patient allopurinol after, of course, management of acute attack, and your target to be less than 6 milligram per deciliter. What about febuxostat? So this one alternative to allopurinol for chronic gout. Okay, so allopurinol, it's prophylaxis for acute attack. The patient first time, and already you managed with whatever non-steroidal or colchicine or corticosteroids. After that, you will continue for allopurinol as prophylaxis. What if the patient has chronic gout? So you can give him febuxostat. This one, the patient has recurrent gout. Also protective, so you will prevent gout to recur again. So you will give the patient vitamin C. Aspirin should not be used in gout. Why? Reduce urinary clearance of urate, interferes with action of uric agents. Non-steroidal anti-inflammatory drugs contraindicated again in heart failure. Remember that. Why? It can cause fluid retention, congestive cardiac failure. So what is the diagnosis, guys, here?
Gout. 2-5 gout.
This one, TOFI, and this one,
This one arthritis.
arthritis. Both of them,
Gout.
gout. Differential diagnosis, you have to rule out septic arthritis, whatever in practice or in the exam, bursitis, cellulitis, tenosynovitis, non-uric crystal-induced arthropathy, pseudogout, rule that. Osteoarthritis, psoriatic arthritis, reactive arthritis, rheumatoid arthritis, trauma. Investigation, so any patient with joint problem, so joint fluid microscopy and culture, you will aspirate. Serum uric acid, joint X-ray. So gout and pseudogout in the scenario, they can ask you by different ways. So gout here, deposition of urate crystals. Pseudogout, deposition of calcium pyrophosphate crystals. Again, so gout, deposition of urate crystals. Pseudogout, deposition of calcium pyrophosphate crystals. Okay. Urate crystals, we are talking about gout, so it's a negative. Calcium, it's a positive. So if you find in the scenario negative, it means it's urate crystals, it means it's gout. If you find the positive, means it's a calcium, it means it's pseudogout. Regarding gout, it can happen in any joint, but most common, first, big toe. Pseudogout in large joints, like knee. So if they mention knee and swelling and think about pseudogout. If they mention the big toe, think about gout. Okay. So this is the difference between gout and pseudogout. So the composition, monosodium urate, here calcium pyrophosphate, and the shape here, as you see, like needle. This one polymorphic rhomboid, and this one negative, this one positive, and this is the image unlikely to give you in the exam. Septic arthritis. So I think we all familiar with that, septic arthritis. So pain and swelling are the most common symptom. the commonest reported site of isolated septic arthritis is knee. So if they give you knee, what is the differential diagnosis now, guys?
Zero gout.
So septic arthritis and pseudogout, right? Fully extended knee, hip abducted, flexed, external rotated. These are the features of septic arthritis. Localized swelling, external to the joint, suggests bursitis rather than septic arthritis. So if they said in the scenario, the patient has localized swelling, it's bursitis, not septic arthritis. They ask you, what is the most likely diagnosis? It shows bursitis. Passive and active movement of the joint will be limited and very painful in septic arthritis. So if they mention limitation of range of movement, think about septic arthritis. Refusal to bear weight will not be able to think about septic arthritis. Fever, chills, rigor may be present in some patients. Septic arthritis is an infection of synovium and joint space. Any joint, but most commonly affects the lower limbs. So if you find the causative organism according to the culture, Staphylococcus aureus, so intravenous flucloxacillin. So if they said you took already knee aspiration and you found it's Staphylococcus aureus in the scenario, and they ask you about the medication, so you will choose IV flucloxacillin. If they mention in the scenario the patient has septic arthritis and they said it's a gonococcal arthritis or gram-negative, so cefotaxime or ceftriaxone. Remember that, please. What about investigation? As we said, X-ray, knee aspiration. So aspirate for microbiology. It will be for gram stain. Can be another question. Gram stain microscopy, white cell count. Polarizing microscopy for crystals. So it will be positive or negative or nothing. Culture and sensitivity. White cell count is the most useful in differentiating between septic arthritis and other diagnoses. The commonest causative organism can be a question, Staphylococcus aureus. Other bacteria that can cause septic arthritis, so maybe Streptococcus, Haemophilus influenza, Neisseria gonorrhea, Escherichia coli. So if the patient sexually active, it shows what? Neisseria gonorrhea. If the patient IV drug user, so it shows Escherichia coli. Okay, this is how to choose the causative organism. Otherwise, Staphylococcus aureus. So nice guidelines, flucloxacillin first line. If penicillin allergic, so clindamycin. If MRSA in the scenario, so vancomycin. Gonococcal arthritis, so it shows cefotaxime. Limb pain and swelling, so maybe rupture of wrist hand tendons. Rupture of tendons may occur without penetrating the trauma. Maybe the patient is lifting something or playing in gymnasium. So maybe rupture of tendons. The most common rupture involves the extensor pollicis longus, a few weeks after, usually and displays the fracture of distal radius. Rupture of other extensor tendon occurred in association with osteoarthritis, rheumatoid arthritis, scaphoid non-union. So refer to hand surgeon. Carpal tunnel syndrome, this one non-traumatic. So compression of median nerve in the carpal tunnel at the wrist. If pressure on the nerve is continued, so you will do segmental demyelination. Muscle weakness and twisting. So here you have to do surgery here. Why? Because pressure on the nerve can cause segmental demyelination, muscle weakness, and twisting. This is a complication of carpal tunnel syndrome. Nerve dysfunction is irreversible, so you have to do surgery as soon as possible. Risk factors, activities with high hand wrist repetition rate and obesity, overuse of hand and wrists, Perimenopause. So if you find any of them in the scenario, think about carpal tunnel syndrome, osteoarthritis, rheumatoid arthritis, hypothyroidism, diabetes mellitus, acromegaly, breast trauma, space occupying region as osteophytes, ganglion cyst. Symptoms: the patient complain of intermittent tingling, numbness, altered sensation, and burning or pain in the distribution of median nerve. So median nerve here can supply thumb, index finger, middle finger, and the radial half of ring finger. So 3.5 digits, lateral 3.5 digits. Symptoms worse at night and can disrupt sleep. Symptoms may affect one or both hands, maybe unilateral or bilateral. Pain in the hand may radiate up the arm into the wrist or as far as the shoulder. The person may complain of loss of grip strength. Signs. So if you will examine the patient, symptoms, it will be mentioned in the scenario from the patient. Here signs when you examine the patient. So sensory loss in the median nerve distribution, weakness or atrophy of sensory muscles, reduced strength of thumb abduction, dry skin of thumb, index, middle fingers, and also positive Fallon test, positive Tinel sign, positive carpal tunnel compression test. Be familiar with each one. Management, so avoidance, modification of exacerbating activities, wrist splinting in neutral position, corticosteroid injection, surgical decompression. So these are the options. Also, non-traumatic, our chapter today, non-traumatic. So think about two syndromes. So this one in the anatomical snuff box. So the Corvain syndrome, and this one will be in the anatomical snuff box. This one, area of pain, distal intersection syndrome. So you have 4 tendons. This one, extensor carpi radialis brevis, extensor carpi radialis longus, and 2 extensor brevis of first finger, and abductor longus of the first finger. So if you find related to the anatomical snuff box, it's called the Corvain syndrome. If you find in the wrist, in the middle, so it's called intersection syndrome. So this is the difference between intersection syndrome and the Corvain tenosynovitis. Anyway, most of these symptoms or features because of repetitive injury, non-traumatic. So both of them the same. You will give analgesia, so immobilize and simple wrist splint unless contraindicated. You will give non-steroidal for 7 to 10 days. Immobilize severe cases in forearm. You will do plaster of Paris for 2 weeks. It's like back slap, 2 weeks before beginning immobilization. So whatever this one or Osgood-Schlatter or severe disease, all these injuries, it's non-traumatic and because of repetitive injury. So again, non-steroidal and inflammatory drugs, some spike splints, and local glucocorticoid injection in severe cases. Epidemiology, woman, 30 to 50 years, most common, maybe postpartum 4 to 6 weeks. The clinical here in the scenario, pain at radial sides of wrist exacerbated by thumb and wrist movements. Finkelstein test. So you will flex the thumb across palm, ulnar deviation, you will do ulnar deviation. It will increase the pain. Okay, you have same, but in the elbow. So tennis elbow, lateral or medial, guys, this one.
Lateral.
And
Extensor.
also, yeah, and golfer elbow. So this one is playing tennis, this one golf, this one lateral, this one medial, and this one extensor muscles, this one flexor muscles. And this one, he has epicondylitis, it will be lateral epicondylitis, this one medial epicondylitis. So again, it's not traumatic, but because of repetitive injury, the patient is stretching his muscles and the tendons. That's why it can cause epicondylitis. And this one, again, same, analgesia, splinting, and rest, same issue. So this one tennis, this one extensor, this one flexor. Lateral epicondylitis, medial epicondylitis, extensor, flexors. So lateral epicondylitis, tennis elbow, repetitive, all same as mechanism. Repetitive or excessive stress to the origin of forearm and hand extensor muscles at lateral epicondyle will cause inflammation, edema, micro tear occur within the extensor insertion. Look for localized swelling, warm tenderness over the lateral epicondyle and immediately distal to it. Examine movements. So you will do dorsiflexion of pronated wrist against resistance. So this test, it can be question. What you will do dorsiflexion of the pronated wrist. It will cause pain. Pain where, guys?
The lateral epicondyle.
Yes, lateral epicondyle. Okay. So X-ray if the problem follows an acute injury. No need for X-ray if no injury, if no trauma. Refer to orthopedic surgeon if there is a vulgent fracture. Treat with analgesia and ice application. Support the arm in broad arm sling and advise rest, followed by progressive exercise, avoidance of aggravating movements. Steroid injection here in severe cases, forearm clasp physiotherapy. Occasional surgery may help. Medial epicondylitis, so golfer elbow, similar pathophysiology. Okay. And here they can mention in the scenario the patient is using racket sport or golf. Examine for localized tenderness, swelling over the forearm flexor insertion at the medial epicondyle. Flexion of supinated wrist against resistance will reduce symptoms. It will be where, guys? Medial
epicondyle. So medial epicondyle, the examination is supination, and the other one is
pronation. Okay. So anyway, if you will do the test in the wrist, ask the patient he has pain where or tenderness where, check in his eye, discomfort in his eyes. So you can ask him, if you feel pain, tell me where, and check his eyes for tenderness. So if medial, he has pain in medial epicondyle, so it's medial epicondylitis. If he has pain in the lateral, so lateral epicondylitis. Patellar bursitis, they can give you this image. Can you see the difference between this knee and this knee? So from the image, it's difficult to diagnose whatever septic arthritis or bursitis, but you have to depend on the scenario as well. So patellar bursitis here, it can be different name in the scenario. Housemaid's knee. Affect people who kneel down. So if they mention the patient, his job is plumber, So think about patellar bursitis because always kneeling. The patient is able to flex his knee. So if they mention that in the scenario supported, may still be relatively pain-free, which makes septic arthritis less likely. Tense extra-articular swelling, superficial to the patella, some overlying erythema. White cell count is likely to be normal. So if you find white cell count high, it's septic arthritis. Otherwise, it's bursitis. Treated with anti-inflammatory, elevation, avoidance of activities. So avoid kneeling. Bursitis may be infected. So they can ask you another question. What is the most likely diagnosis? Patellar bursitis. What is the most likely complication? Septic arthritis.
Septic arthritis.
Yeah, especially after breaks in the skin and may need antibiotic and surgical drainage. So here prophylactic antibiotic is flucloxacillin. Remember that, it can be a question. So even prophylaxis, the patient has bursitis and no complication. Yes, you can give flucloxacillin to prevent septic arthritis. Plantar fasciitis, so the same issue, non-trauma. Okay, so here it's overuse. Overuse injury or repetitive injuries, so all are the same. Increasing burning pain in the sole of the foot and heel, worse on weight bearing. Examine for localized tenderness over calcaneal insertion, as you see, of the plantar fascia and the heel band. X-ray may reveal calcaneal spur, but this is not useful diagnostic feature. You will give the patient non-steroidal anti-inflammatory, rest elevation 1 to 2 days, follow up with GP. Padded shoe insole may help. Local steroid injection and surgery in severe cases. Condition number 5, spinal pain and radiculopathy. So radiculopathy means pain in one or both of upper extremities to the dermatome of involved cervical nerve roots. So if the patient has pain, so it's a radiculopathy. The patient has weakness, what is called, guys?
Myopathy.
Okay, so it's secondary to compression. The patient has compression in the neck because we are talking about cervical. Irritation of nerve roots in the cervical spine. Causes here may be degenerative changes like cervical disc herniation or spondylosis, maybe trauma, so non-traumatic or trauma. Symptoms, pain in the neck, shoulder and or arm that approximate to that dermatome, usually unilateral, maybe bilateral. The pain may be severe enough to wake the person at night. Sensory symptoms such as absent or altered sensation, shooting pain, you will say shooting pain, numbness, hyperesthesia. Motor symptoms, the patient has weakness, gradual onset. The most common nerve root affected is C7 followed by C6. Remember that. So in spinal pain radiculopathy, the most common is C7 followed by C6. Signs, postural asymmetry. You will find the patient is standing, but there is asymmetry. Maybe turn to the left side or turn to the right side, so asymmetry. The head held to one side or flexed. Why? To decompress the nerve root. The patient feel comfortable with this position because the patient has compression. He will do flexion or tilting to his neck because it will relieve the symptoms. If the asymmetry is long standing, it can cause muscle wasting. Any patient he has muscle wasting, it means he has nerve problem. If you find patient has a right cheek different than left cheek, he has wasting, he has nerve problem before. Okay. Patient has muscle wasting in deltoid, he has problem in this muscle, in this nerve before, and so on, because he is not using the muscle. Neck movements, it will be restricted or sharp pain may radiate into the arm. Oral irritation. So Sperling test, you will flex the neck laterally, rotate and then press on the top of head. So the test is positive if the patient has pain, radicular arm pain. So it means you are doing irritation to the nerve. You are worsening the symptoms. So it's called Sperling test. Neurological problems, upper limb weakness, paresthesia, dermatomal sensory or motor deficit, diminished tendon reflexes at the appropriate level. Atypical signs of cervical radiculopathy, so the patient has deltoid weakness, scapular winging, weakness of intrinsic muscle of the hand, chest or deep breast pain, headache. So these are atypical signs, not typical. Okay, so be familiar, please, with the nerve roots and the muscle affected, the reflex change, sensory. So in any neurological manifestation regarding any nerve root, motor, sensory, reflexes. Motor, sensory, reflexes. So you can read this slide, guys. You can review later. So check for C5. They can give you patient with shoulder abduction problem or flexion, elbow flexion. So what is the nerve root affected? C5. Biceps reflex, it change, C5. Sensory. So the patient has loss of sensation or decreased sensation on the lateral arm, C5. And if they mention elbow flexion, weakness, wrist extension, weakness, C6. Biceps or supinator, C6. We're talking about reflexes. Lateral forearm or thumb or index finger, decreased sensation or lost sensation, C6, and so on. So the most important, understand the feature. So here, decreased weakness. Sorry, there is weakness and maybe absent or decreased reflex, maybe absent or decreased sensation. So middle finger, C7, and so on, okay? Differential diagnosis. So the patient has a spinal pain and radiculopathy, same as back pain. Same as back pain. So back pain, neck pain, or a spinal pain, radiculopathy, the same causes, okay? But here in radiculopathy, we are talking about from cervical, spinal cord, up to fingers. So maybe the problem central, maybe the problem peripheral, okay? So maybe abscess, whatever central or peripheral, you will find in the scenario fever, neurological deficit, and pain. Maybe anterior interosseous nerve entrapment, so the patient cannot grip and bench, but no pain. Arteriovenous malformation, the patient has numbness, paresthesia, variable pain, and weakness. Carpal tunnel syndrome, it will be in the hands. So numbness in radial 3.5 digits, paresthesia, senor weakness. Senor weakness here because of median nerve is not using. Cubital tunnel syndrome, it will be in the elbow. Herpes zoster, so they will mention the patient has rashes, so think about herpes zoster. If the patient has radiculopathy and he has rashes, think about herpes zoster. Posterior interosseous nerve entrapment, it will be in the finger, wrist weakness, pain. Radial tunnel syndrome, pain only at the radial forearm. Reflex sympathetic dystrophy, the patient has edema, pain, skin discoloration. Rotator cuff tendonitis, the patient has shoulder pain with potential radiation to arm. So each can be a scenario and each can be diagnosed. What is the most likely diagnosis? Thoracic outlet syndrome, the patient in the scenario has pain, swelling, vascular insufficiency. So think about thoracic outlet syndrome. Again, the investigation, cervical X-ray, and other imaging studies, whatever CT or MRI, and the investigation are not routinely required to diagnose neck pain with radiculopathy. So any patient with radiculopathy or symptoms, so it's not a routine until the patient has symptoms of red flag. So here MRI and complex cervical radiculopathy. If you have suspicion, high suspicion for myelopathy or abscess, persistence or progressive objective neurologic findings, or failure to improve after 4 to 6 weeks of conservative treatment because maybe malignancy. Osteoarthritis. So here, regarding osteoarthritis, typical radiological feature of osteoarthritis, you can find subchondral bone thickening. It's called sclerosis. So this one, the image, you can find osteophyte, joint space narrowing, subchondral sclerosis. So it's not emergency, but anyway, you have to be familiar with that. So subchondral bone thickening, sclerosis, osteophyte formation, loss or narrowing of joint space. Structural change on X-ray may not correlate for reported symptoms and functional impairment. Here, complications can be a question: joint deformity, functional impairment and disability, psychosocial impact, occupational impact, falls, chronic pain syndrome. So the management here, analgesia, paracetamol, another option, topical non-steroidal anti-inflammatory, oral non-steroidal anti-inflammatory, opioid is an option, topical capsaicin, intra-articular corticosteroids for moderate to severe joint pain. Also, risk of rheumatological disease-modifying drugs. So think about ankylosing spondylitis. This is a healthy spine. This is a normal body of vertebra. This is a normal disc. If there is inflammation of joints, it will be decreased in size like that. It will be inflamed. Increased inflammation, it will cause fusion of bones. The vertebral bodies will fuse together. So it's called bumboid spine. So it's ankylosing spondylitis. So suspect ankylosing spondylitis in anyone with chronic or recurrent low back pain, fatigue, stiffness. Okay. If you find in the scenario, the patient has chronic or recurrent low back pain, fatigue, stiffness, and his age 45 or younger, back pain more than 3 months, back pain, stiffness, inflammatory. Worse in the morning, more than 30 minutes, improving with movement. So think about ankylosing spondylitis. Symptoms, wake them at night, in the night. Symptoms respond to course of non-steroidal anti-inflammatory drugs because it's inflammation. If you give him anti-inflammatory, it will improve. Family history of ankylosing spondylitis or spondyloarthritis. Other conditions with similar presentation have been excluded. So you should exclude other conditions. They have current or previous buttock pain, pain in thoracic or cervical spine, arthritis, anterior uveitis, psoriasis, inflammatory bowel disease, genitourinary infection. So if you find any of these features, think about ankylosing spondylitis. Spinal infections, it's very important. The Royal College put in condition 7. So vertebral osteomyelitis or discitis or epidural abscess. It can arise from hematogenous spread. The patient has a blood infection. That's why he has a spinal infection, or direct extension of infection from the spine or paraspinal tissue. The patient has local infection, after that spread to the spine. A spinal epidural abscess threatens the spinal cord or coda equina by compression and vascular compromise. Sensory symptoms and signs, motor dysfunction and paralysis, and this can happen. The most common source of spinal infection, Staphylococcus aureus. Remember that, followed by Escherichia coli. The red flags to diagnose in the scenario we discussed already: fever, TB, UTI, diabetes, IV drug user, HIV, immunocompromised or immunosuppressed. Condition number 8, torticollis. Acute torticollis in pediatric, diagnosed clinically. The patient doesn't have trauma. In typical cases, which present within 1 to 2 days of onset of symptoms, investigation here not usually required, no need for investigation. Any patient with torticollis, just give him a painkiller and reassurance. Offer people with acute torticollis oral analgesics, ibuprofen, paracetamol, or codeine. Consider prescribing muscle relaxant. Explains that acute torticollis usually resolve within 24 up to 48 hours, just reassurance. Limping a child, here, be familiar please with all ages, and according to the age, you can decrease your differential diagnosis. So in all ages, trauma can cause limping. So maybe fracture, hemorrhagitis, infection, like septic arthritis, osteomyelitis, discitis. Secondary to viral illness, like the patient has osteomyelitis or septic arthritis, or also if child 1 to 3, maybe tenosynovitis. Tumor, sickle cell disease, if the patient has sickle cell disease and he has limping or pain, so it's a crisis. Serum sickness. So according to the age in the scenario, if they give you the patient in the scenario 1 to 3 years, think about transient synovitis, toddler fracture, maybe abuse, developmental dysplasia of the hip, neuromuscular disease, hemophilia, institutional purpura. If the patient 4 to 10, the most likely Behçet's disease. If you find in the scenario patient has 4 years, 5 years, 6 years until 10 years, think about Behçet's disease or institutional purpura. Patient in the scenario more than 10 years, think about SOFI or think about overuse syndrome. If the patient has problem in the hip, SOFI, problem in the knee, so it will be Osgood-Schlatter or severe disease. Osgood-Schlatter where, guys? Which joint?
Tibial.
Knee
joint.
Okay, so overuse here. And if the patient has severe disease, where?
Calcaneum.
Okay, and okay, osteochondritis, this can. So this one we'll discuss now. So transient synovitis, it's a self-limiting inflammatory disorder. We said 1 to 3 years of the hip, more common in boys than girls. You'll find the scenario male, boy, and rare in children aged younger than 3. Mild to moderate hip pain and limb. There is no restriction of hip movement. The patient in the scenario, they will not mention a restriction. So it's tenosynovitis. Children are otherwise well, afebrile. History of viral illness, whatever 3 days or 4 days. Flu symptoms. Absence of viral illness doesn't rule. So it rule in, but doesn't rule out. Diagnosis of transient synovitis, one of exclusion. Also, you have to exclude septic arthritis. It's a common question in limping child. So, Kocher criteria, history of fever, more than 38.5, non-weight bearing on the affected side, SR greater than 40, serum white blood cell count more than 12. So remember that you have 4 criteria. Septic arthritis is more likely if these features are present. So it's 1 point or 1 criteria, it's 3% septic arthritis. If you find 2 criteria, it's a 40% septic arthritis. If you find 3 criteria, it's 93 septic arthritis. If you find all 4 criteria, it's 99 septic arthritis. Again, if you find in the scenario more than 38.5, if you mention in the scenario non-weight bearing, if you find SR more than 40, and Watson count more than 12. SOFI, I think we are familiar with that. More common in boys than girls. So tenosynovitis and SOFI more common in boys. And also overweight. Associated with hypothyroidism, growth hormone deficiency, radiotherapy treatment. If you find any of these risk factors in the scenario, high suspicion of SOFI. Sudden onset of severe hip pain with leg held in external rotation. Child may walk with antalgic gait with shortening of the affected leg. What is the view? It's a common question. So AB and the frog leg lateral X-ray. What is the finding? It's a common question. Widening of epiphyseal line or displacement of femoral head. So, of course, you will check for there is 1 sign. It will be on the AB view. So it's a clean line drawn along the superior border of femoral neck, passes above the femoral head. And instead of intersecting the femoral epiphysis as in the normal head. The most complication, avascular necrosis. Also limbing the child, but here, SOFI, it will be in the hip. And regarding overuse disease, so Osgood-Schlatter here, this one. If you find this X-ray, it's Osgood-Schlatter. So what is the finding here, guys?
Fragmentation of tibial tuberosity.
Fragmentation of tibial tuberosity or the tendon, patellar tendon. And here also severe disease. So the same idea, overuse. So fragmentation here of calcaneal. So this one knee, this one ankle, this one here. What is the diagnosis versus disease? As you see here, the femoral head, it's normal here, but here femoral head fragmented. Okay, and what happened here? Decrease the blood supply to the femoral head. That's why it causes versus disease. If neglected, it will cause which complication?
Avascular necrosis.
Avascular necrosis. Okay. So also there is a space, big space between the head and the hip. The last condition, osteochondritis. So they can give you this X-ray, as you see here, shadow, and also maybe this lesion. Okay. So this one is still in place. This one displaced. Okay. So this one, cartilage or bone in joint is inflamed. Okay, which of the following would be the most appropriate next treatment option, guys?
Low dose.
Codeine phosphate.
Okay. Which of the following pharmacological service is recommended by current NICE guidelines?
Diazepam for mother.
Diazepam for muscle spasm.
Okay, diazepam for muscle spasm. Which risk stratification tool is endorsed by current NICE guidelines?
Start
Start.
Okay, start the back risk assessment tool. Which of the following would be the most appropriate treatment?
Diazepam.
Diazepam.
Okay, diazepam. Because he said muscle spasm. Which of the following pharmacological service is not recommended?
Paracetamol alone.
Excellent. Which of the following is the first line pharmacological therapy for low back pain recommended?
Ibuprofen.
Ibuprofen.
Excellent. Which of the following is a red flag feature for infective cause?
Use of
Immunosuppressant drugs.
Option 2.
Excellent. Which of the following pharmacological service is not recommended?
opioids for chronic
Option
pain.
A.
Opioids
Cure for chronic back pain.
Not recommended. Following features would make you suspect spinal fracture.
Relieved by lying down.
Option B.
Second option.
Sudden onset severe
Sudden
stimulus.
onset severe central spinal pain, which is relieved by lying down. Excellent. Whatever traumatic or non-traumatic, guys. Okay. Most likely cause of his symptoms.
Herniated Option 2.
Excellent. Why not to choose Coda-Equina syndrome?
Because there is no urinary
No
No
autonomy.
sudden anesthesia or no urinary or foul.
There is no sudden anesthesia.
Okay, but here, what is my point? He's asking about the cause, not
The cause, not the complication. Yes.
Yes, he did not say what is the complication or what is the diagnosis. He's asking about the cause. So discitis here, it's a cause. Spinal stenosis, it's a cause. Vertebral fracture, it's a cause. So the following features would make you suspect malignancy.
Thoracic pain, I think.
First one.
Thoracic pain.
Excellent. Spondylosis typically affects which part of the vertebra?
Pars interarticular.
Pars interarticularis.
Okay. Which of the following is a red flag feature that is indicative of infective cause?
IV drug use.
Intravenous drug users.
Excellent. Which of the following features would make you suspect inflammatory cause?
Option D.
Relieved
Stiffness in
by-
the morning. That is
Stiffness in the morning.
exercise. Option D.
Excellent.
Stiffness in the morning.
Given his symptoms, what level? We have two levels, lumbar 4, lumbar 5, and lumbar 5 is 1.
Last option.
Last option.
L5S1. He
Yes,
said
why?
lateral left foot.
So on examination, altered sensation over the lateral left foot. What does it mean, lateral?
Little toy.
Little toe.
Small toe.
Small toe is S1. Big toe is L5.
And also he said left ankle, plantar flexion. Okay. Single most likely diagnosis.
Gout. Gout
Gout.
because of diuretics.
Diuresis. Okay. Single most likely diagnosis.
Gout.
Gout.
Yes, but we don't have here TOFI, so we'll choose gout. TOFI or
Yes,
arthritis, it's a gout.
Yes.
Gout.
Gout.
Okay. How should this patient managed?
Oral
So
non-steroidal.
check first it's
Oral
acute attack or
non-steroidal.
not.
Oral NSAID.
He said
Acute,
acute, painful right too. So
That's it.
the first is
Oral non-steroidal. Non-steroidal.
okay, non-steroidal. But also check if there is any contraindication. Any allergy here? No.
Yes. No.
Any heart failure?
No.
No. What
Mm.
else contraindication?
Ineffective.
Ineffective. لا.
Okay.
أي الهارت فين؟
What is the most likely diagnosis?
Big toe.
Gout.
Goats.
Excellent. Because of
Hot tender swelling.
Pain in the
Big toe.
morning and most.
not typical feature of Coda equina syndrome.
Upgoing plantar.
Upgoing plantar.
Why is this one for what?
Meningitis.
It should be downward.
Spina medullaris.
Sciatica.
Sciatica. Sciatica also.
Single most likely diagnosis.
Coda equina.
Coda equina syndrome.
Coda equina.
Okay, sphincter tone is lax. All the standard investigation.
MRI.
MRI. What investigation should be performed as priority?
Incontinence. MRI.
MRI.
MRI
Coda equina syndrome. Saddle anesthesia. Most useful initial investigation. Sedation.
Prostatic cancer with also MRI.
MRI also.
MRI.
Because
What is the diagnosis?
Metastatic.
Metastatic.
Prostatic
Okay,
cancer.
spinal metastasis. Spinal metastasis. Okay. Following would make suspect Coda equina.
Laxity of
Type of crystal.
negatively bifurcated.
Number 4.
Needle shape.
Why?
Gout.
Gout.
Because of he said metatarsophalangeal joint, so you suspect gout. Okay, and here should be negative.
Needle shaped.
Most commonly affects which joint?
Big toe. Big toe.
Okay. Not typical feature of rheumatoid arthritis.
Bony nodules.
Bony nodules on proximal
Okay. Single most appropriate next management option.
Prednisolone. Comment prednisolone.
Okay, excellent. Why?
Myelodysplastic
Diagnosed with
Yes,
myelodysplastic
myelodysplastic
syndrome.
syndrome. So
Colchicine is contraindicated.
it's a contraindicated because it will affect the bone marrow, neutrophilia, and thrombocytopenia.
Thrombocytopenia.
Single statement regarding the treatment.
Colchicine has a role in prophylaxis.
Excellent.
Heart failure.
Okay. So colchicine here you can use as prophylactic and acute management, right? Single statement regarding treatment of acute gout.
Option C.
Naproxen.
Option C.
Excellent. So first line. Single most appropriate next management step.
Colchicine. Comment colchicine.
Colchicine. Okay. Why?
Heart failure, ramipril.
Patient is an antihypertensive medication.
Excellent. He's using ramipril. So any signs of contraindication. Any sign for contraindication for non-steroidal, go for colchicine. Single most likely diagnosis.
Pseudogout.
Option B.
Pseudogout. Okay. Why?
Positive neighboring crystal.
Negative.
Gout.
Gout.
Crystal deposited in joint in pseudogout.
Pyrophosphate crystal.
Okay. Type of crystals are deposited in joint in gout.
Urate.
Crystals.
Condition not considered. Metabolic syndrome.
Hyperthyroidism.
Hyperthyroidism.
Hypothyroidism.
What is the diagnosis? Perfect.
Gout.
Gout.
Gout arthritis.
Single most appropriate.
Tylenol and commence naproxen.
Continuous albuterol and commence naproxen. Okay. Crystal, what do you expect to see in present of pseudogout?
Positive
PB.
vibration, big shape.
Positive. Big shape.
Positive vibration.
Most likely diagnosis?
Septic arthritis.
Excellent. Why?
Tension.
White
No
blood
throat.
cells.
How do you
Probably says 21.
Ulcerative trauma.
Febrile
Febrile.
and
Febrile.
Limitation of movement.
irritated, refusing
Because
to move,
let your back, yeah.
and the white cell count also high.
Okay.
Which of the following antibiotic most appropriate? Gram-positive.
Option B, intravenous fluoxetine.
Fluoxetine.
Isolated septic arthritis. Common
Knee.
site.
Option D.
Knee.
Knee.
Following is most likely causative organism. So
Diplococci.
Bacteria.
Last option.
Neisseria.
Neisseria.
Neisseria gonorrhea.
Neisseria.
Why?
Because you return from the holiday.
Bangkok.
Young
Sure.
patients who just
Young
returned from
patient
holiday
and
in Bangkok.
recent of travel, maybe also sexual.
Yeah.
Active.
Most likely causative pathogen.
Aureus.
Staph aureus.
Staph aureus.
Staphylococcus. Okay. Following investigation, definitive diagnosis.
Joint aspiration.
Who has noticed arthritis?
Option
Joint aspiration.
D.
joint aspiration.
Joint aspiration.
Which nerve or nerve root is affected?
Median nerve.
Median nerve.
Carpal tunnel syndrome.
Okay. Most likely diagnosis.
Ideal aspect of the hair loss of
Plantar fascia.
Plantar fasciitis.
Plantar fascia.
Okay. What is the diagnosis?
Lateral epicondylitis.
Lateral.
Lateral
Okay.
condyle
Because he said extensor aspect,
Extensors.
aspect. Yeah.
not feature of carpal tunnel syndrome.
abduction.
Adduction.
Last option.
option.
Last
Okay.
option.
Likely
And
diagnosis.
Carpal.
Carpal tunnel syndrome.
Okay. Most likely diagnosis.
Left knee.
He has large erythematous swelling.
Prepatellar bursitis.
Bursitis.
Patella bursitis. Patella
Excellent.
bursitis.
Yes.
Yes.
So here he said fully flex his
Able
knee
to fully flex.
and relatively
Relative-
pain-free. So exclude what?
Arthritis.
Septic arthritis. It's not septic arthritis.
Caput fitter.
Okay. Most likely diagnosis.
Cervical radiculopathy. Option 2.
Excellent. Okay.
Yes, and
So any patient with neck pain and he has neurological symptoms, think about cervical radiculopathy. Nerve root is most likely affected.
6.
6.
Okay.
6.
Not typical feature of osteoarthritis.
Costocancer.
Option E.
Could
Option E. Chondrocalcinosis.
Okay. Ankylosing spondylitis.
Asymmetric tenderness on valve.
Option
3.
3. Option 3. Pain present in
Okay.
waking in the morning.
most likely diagnosis.
high fever.
Epidural abscess. Epidural abscess.
Option
Abscess.
Option A.
First one.
A.
Yes. And high fever.
You have fever here. So fever here, it can give you abscess or malignancy, right?
Yes.
IV drug user.
Yeah.
Is it
mild-
IV drug user?
Mild grade fever, it will be malignancy. Like for example, 37.9, something like that, or 38. But 39, it's infection. And also IV drug use.
Yeah.
Infective cause,
History of IV drug user. B.
Intravenous. Intravenous.
most likely pathogen.
Staphylococcus aureus, IV drug user.
Okay, Staph aureus, until proven as
Point.
management.
Option D.
Oral analgesia.
Oral analgesia.
Okay.
Analgesia.
The patient here, 27, neck pain, present on walking, denies trauma, so no red flag for trauma, holding his neck in 20 degree, so he's trying to do decompression, okay, and rightward rotation. Any attempt movement of the neck is painful. You cannot find any abnormal upper limb neurology. So there is no red flag. Just prescribe oral analgesia and reassure the patient.
Dr. Hani.
Most likely
Dr.
diagnosed.
Dr. Hani,
Yes.
regarding this
Practice.
these conditions,
This one?
this condition, red condition for pediatric,
Yeah.
it is for pediatric or for every age يعني in exam? If they say that,
Yeah. Actually, any red color should be for pediatric only. But here, it can happen in any age, torticollis. Sometimes,
Yes.
Me, for example, sometimes I wake up with torticollis, okay?
yes, I know it is in every age, but in exam it
In
should
the
be
exam,
for
for the purpose of the exam, they will give you the age of pediatric.
Okay, sir, thank you.
Yeah. But please don't depend on that. Okay? Sometimes they will say male to female, like 20 to 1. But don't depend on that. Okay? Most likely diagnosis.
Transient
Five.
synovitis.
Transient sinusitis.
Option D.
Pertussis disease.
Pertussis.
Transient
Option
Yes,
D.
yes.
Transient synovitis.
Why?
Yes, because viral.
Because patients just recover from nasty cold.
Ephemeral, normal
And
observation,
febrile and normal observation.
recovered from nasty cold. It means he has flu symptoms like 3 days, for example. Okay?
Viral infection, yes.
Yes, viral infection. And here also, he said, passive movement of the right hip is painful, limited at the extreme range of movement. Okay. Most likely diagnosis.
Sophie.
Sophie.
More than 10 years, Sophie, until proven otherwise. 3 years,
CRP.
yeah.
CRB more than 50.
Not part of cohort option.
CRB.
Last option.
Last
CRB.
option. CRB.
Yes.
Osgood and
Oh,
option
Scott
B.
Scotland's disease. D. Option 2.
Okay.
B.
2.
Diagnosis.
Severe disease. B.
Sever's disease. B.
Most likely diagnosis.
Bears.
B.
Parker's
disease.
disease.
Yes.
Thank you guys. Inshallah tomorrow and should be in